Hello everybody. Welcome to number 1 Doctor channel. Today video is about appendicitis, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about appendicitis. Appendicitis is an inflammation of the appendix that results from bacterial invasion, usually distal to an obstruction of the lumen. Appendicitis begins with obstruction of the narrow lumen by lymphoid hyperplasia, fecal material, fecal length, foreign body seeds or worms, etc. Following obstruction of the lumen, a continued secretion of mucus produces distension of the distal end. The distension results in ischemia of the wall with bacterial proliferation. Subsequently, Apache necrosis, gangrene and perforation develop, resulting in peritonitis and sepsis, and finally death. Symptoms: central abdominal colic which shifts to a pain in the right iliac fossa, anorexia, nausea, episodes of vomiting and low-grade fever. High-grade fever usually indicates perforation and peritonitis. Signs: tenderness and localized rigidity in the right lower quadrant over MC Bernese point, 2 inches from the anterior superior iliac spine on a line drawn to the umbilicus. Rovsing's sign: pain in right lower quadrant on pressing in the left lower quadrant. Psoas sign: pain on extension of the right flexed hip. Obturator sign: pain on passive internal or external rotation of the flexed right hip. Right-sided tenderness on rectal examination. Diminished bowel sounds indicating peritonitis. Differential diagnosis. In children. Intussusceptions. Mesenteric adenitis. In female patient. Pelvic inflammatory disease. Right salpingitis. Ruptured ectopic pregnancy. Twisted ovarian cyst torsion, ruptured ovarian follicle. In general population. Acute cholecystitis, perforated peptic ulcer disease, renal or ureteric calculi, urinary tract infection, early small bowel obstruction, volvulus gastroenteritis, referred pain from the pleura, basal pneumonia. Management: resuscitation of the patient with fluids and other supportive treatment. Appropriate antibiotics combination for coverage of gram-positive, gram-negative and anaerobes. Correct all deficits. Dehydration. Surgery. Surgical removal of the appendix is the definitive treatment. N.B. Close follow-up of surgical patient is very important post-operatively to identify complications as early as possible and correct in time. Complications. Complications of acute appendicitis include perforation with local or generalized peritonitis, appendiceal mass and abscess formation. Delayed diagnosis and treatment may lead to complications and death. Management of appendicular mass. If appendicitis is not recognized and treated early, it may progress in one of two ways: 1. Perforation and peritonitis. 2. Organized appendiceal mass or progress to appendiceal abscess. The inflammatory process may become walled off in the right iliac fossa by omentum and loops of bowel to form a mass. The management of appendix masses conservatively with combined antibiotics for anaerobes, aerobes and gram-negative bacterial and fluids. The drug of choice is a combination of metronidazole and ceftriaxone if available. If this combination is not available, use ampicillin, chloramphenicol and gentamicin instead. Patient should be followed up, strictly monitoring the vital signs every 4 hours. The mass size and consistency 12 hourly. Patient's condition and laboratory every other day. If the mass settles on conservative management, the patient can be discharged and readmitted for interval appendectomy 6 weeks later. Otherwise, if there is any sign suggestive of progression to an abscess, increasing mass size, fluctuation, persistence of systemic signs, emergency laparotomy has to be done for drainage of the abscess and appendectomy if the appendix is easily found. If the appendix is embedded in a conglomerated mass, one should not struggle to deliver it for fear of damage to surrounding structures. Interval appendectomy after emergency drainage is preferred in this case. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.